we have 3 talks today, and we have a session on diagnosis and localization of ventricular arrhythmias. We don't have Peter Van Dam talk, so we'll have to leave without it, but we have 3 other excellent talks, and let me just invite our first speaker, Emir Baskovski from Turkey. We're going to talk about practical approach to differential diagnosis of wide QRS complex tachycardia. That is a difficult topic. Emir, please.
Okay. Hello, everybody. Thank you for inviting me to this organization, to this congress. Actually, here in Turkey, I'm on congress too. We're having our arrhythmia working group annual meeting, and I just had a presentation about 3D mapping and stuff, and I was running here. I'm happy to be on time here for my presentation. Now I'm gonna share my slides. Let me see. Yeah, can anybody see my slides? Is it okay?
Yes.
Okay, thank you. Thank you so much. So I'm since we have a 10-minute limit, I tried to keep this presentation clear and concise. Let me get started on it. So any tachycardia with a QRS that is longer in duration than 120 milliseconds is referred to as a wide QRS tachycardia. Most of the time, like 80% of the time, it's a ventricular tachycardia. But there are also other causes of wide QRS tachycardia. Supraventricular tachycardia with aberrancy is around 15 to 20% of the time, and pre-excited SVT with pre-existing QRS abnormality, but also SVT in a patient taking antiarrhythmic drugs, and also ventricular pacings and electrolyte abnormalities can cause a tachycardia with a wide QRS complex. So first, as a doctor, the first thing we have to think systematically, and the first thing that comes to mind is a clinical history. So age, patients older than 35 years have a greater likelihood of having a ventricular tachycardia than younger patients. Symptoms, they occur in both supraventricular and ventricular causes of wide QRS tachycardia, and the severity of the symptoms is never useful. So it is easy to think that VT can cause a hemodynamic compromise, but also some very quick supraventricular tachycardias with pre-excitation can also cause severe symptoms. So symptom severity is definitely not a very useful marker for differential diagnosis of a wide QRS tachycardia. What we do know is that presence of an underlying heart disease means that ventricular tachycardia is more probable, and in patients that have a history of myocardial infarction, a wide QRS tachycardia is over 90% of the time caused by a ventricular tachycardia. Now, when we come to physical examination, it's not only the blood pressure that's important, and definitely it doesn't aid in diagnosis some of the times. However, evidence of a atrioventricular dissociation is very important, and whenever we do observe this, we can diagnose a ventricular tachycardia. When we cannot see this atrioventricular dissociation, we can, due to fast VA conduction, we can do some carotid sinus massage to try to slow down the conduction between ventricles and atriums and try to observe the Cannon A waves on the jugulars. So the golden rule here is an unknown wide QRS rhythm should be presumed to be a VT unless it is proven otherwise. Now, when we see a wide QRS tachycardia rhythms on a ECG, the first thing that I do look at is precordial V1 derivation. At V1, if we see a right bundle branch like pattern, it's a right bundle branch like wide QRS rhythm. And if we see a negative, predominantly a negative waves on V1, it is a left bundle branch like tachycardia. We still don't know whether it is a SVT with aberrancy or whether it is a VT. Here on C, we can see some arrows. They point to A waves, to P waves, but it is not always observed very easily. When we do see AV dissociation on the ECG, as we see on the screen, it is a probable diagnosis, a definite diagnosis of ventricular tachycardia. Here, P waves are marked with arrows. You can see them clearly on D2. Now, the second thing we're going to talk about is the QRS axis. When we see a tachycardia, white QRS tachycardia with the leftward axis, this raises the possibility that tachycardia is actually a ventricular tachycardia. Also, when we see a right superior or northwest axis, the specificity of that tachycardia being a ventricular tachycardia is 96%. So this is very specific. However, it is not very sensitive. The other thing is a precordial concordance. This criteria is very easy to observe, but it is not observed very often. We have negative concordance and positive concordance. Negative concordance means that all precordial leads are Q waves and there is no R. The positive concordance means that there are no Q waves and S waves on the precordial derivations. So if it is a negative concordance tachycardia, this raises the possibility that this ventricular tachycardia exits from the apex of the ventricles. And if there is a positive concordance, this is probably a ventricular tachycardia originating from some basal portions of the left ventricle. Now, the sensitivity of this criterion is around 20%, and the specificity is 90%. Now, the other criteria for diagnosing, for differentiating between SVT and VT is a QRS morphology. When we have a white QRS tachycardia with a right bundle branch block-like pattern, there are these specific criteria like monophasic R wave, biphasic QR complex, or a broad R wave that, if we observe, favors a ventricular tachycardia. On V6, if we see an RS, a QR big S, a small r with an S, a QS pattern, or an RS ratio that is less than 1, this suggests that we have a ventricular tachycardia. However, since septal activation is intact during right bundle branch block, during SVT, we see triphasic patterns on V1 like RSR, and this favors SVT. On V6, an RS with a small s favors the diagnosis of SVT. On the other hand, when we have a left bundle branch-like pattern, we know that during the left bundle branch block, the septal activation proceeds from the right to the left. Therefore, on V1 or V2, no R wave or R wave that is shorter in duration than 30 milliseconds favors a supraventricular tachycardia. On the other hand, on V6, absence of a Q wave favors a supraventricular tachycardia. What is the morphology that suggests the QRS morphology that suggests ventricular tachycardia on V1 or V2 is a broad R wave or RS interval that is longer than 70 milliseconds, but also notching of the downstroke of the S wave favors ventricular tachycardia. On V6, presence of a Q wave or a QS complex favors ventricular tachycardia. Now that we know all this, it is time for an algorithm that helps us differentiate between SVT and VT. So the Brugada criteria is probably the best known algorithm. It has been proposed almost 30 years ago in 1991, publication on circulation. So the step 1 of Brugada criteria is, do we have absence of an RS complex in our precordial leads? If we do, it is a diagnosis of ventricular tachycardia. But if we don't, then we have to check from R to S interval, and if it is bigger than longer than 100 milliseconds, we diagnose a ventricular tachycardia. The sensitivity is 0.66, the specificity is 0.98. However, if the R to S interval is shorter than 100 milliseconds, we seek out to find whether we do have a atrioventricular dissociation present. If we have an AV dissociation, it is AVT. However, if we don't have an AV dissociation, we move to the next step, which is a morphology criteria for VT present in precordial release, V1 and V2 and V6. We just discussed that before. If the morphology criteria is positive, then we diagnose VT with a sensitivity of 0.98% and specificity of 0.96%. However, if we don't, we can obviously diagnose a supraventricular tachycardia with a sensitivity of 0.96 and specificity of 0.98%. There are newer algorithms like the Verke algorithm and also the LIMP algorithms. They all are similar in a way that they look out for AV dissociation and the presence of the R wave in AVR and like QRS morphology. However, what is crucial here is that during a ventricular tachycardia, the initial activation of the ventricles is very slow since it does not proceed through the His-Purkinje system. However, the opposite is true during the SVT, since it is the rapid activation goes through the His-Purkinje system. The initial portion of the QRS complex is usually very fast with with bigger waves, and the activation proceeds in a typical way in such weeks as we expect in left bundle branch block or right bundle branch block, right bundle branch block or right bundle branch block plus a fascicular block. I would like to thank everyone for listening to me. Any questions I may take?
Thank you very much. Let's see how we do. We have 10 minutes reserved in the end for the discussion, guided by two colleagues, and one of them, Mert, İlker, Hayıroğlu, I see has joined us already. If anybody has one burning question, I guess we can take it now. Otherwise, we would move to next. Anybody? So I think we can have. Then maybe we'll continue the discussion for the 10 minutes reserved in the end of the session that will be guided by two of our colleagues. Konstantinos, would you present the next speaker?
Yes, of course. Just 1 second. Check my mails. The next speaker.
Emir, you didn't say anything about esophagus ECG. Is it something that you routinely use in your practice to distinguish between ventricular arrhythmias and supraventricular with aberrancy white complex?
Yeah, it's a good question. I only did a esophagus ECG once, and I really had some trouble taking good recordings. So not routinely. I just did only once. So I don't know about your experience, but I haven't.
Let me ask other panel members, Konstantinos or Mert, how do you use it routinely?
I mean, can you hear me?
Yes, we do.
Yeah.
I did not use esophagus ECG in my routine clinic, but I want to ask something to Emir while we are waiting for Yaodong Li and Enes. In distinguishing between supraventricular tachycardia and VT.
Hear me now?
In our routine clinic, we
Yes.
need less than 10% to electrophysiological study to distinguish the VTs from supraventricular tachycardias. What is your frequency to use electrophysiological study to distinguish between ventricular tachycardias and supraventricular tachycardias? Because these patients have already taken antiarrhythmic drugs to to stop their wide Qrs tachycardias. What is your routine to use electrophysiological study to distinguish between them? Is ECG is enough, or do we need more?
Yeah, well, thank you for your question. Actually, doing an EP study to distinguish VT and CVT, SVT is very rare in my experience. Usually adenosine helps. I didn't discuss that because of this short time. I tried to keep my slides concise. Adenosine also helps. I think it is very rare to have a patient that needs a EP study to differentiate between those, and I agree with you. It's likely less than 10%.
Okay, nice. I have also some comments. Sorry for the background noise. I'm in a hotel for another congress. We have to say that everybody with a wide QRS tachycardia has to be checked for a structural heart disease. This is the most important part. Okay, this is the first step of differentiation, and we have to keep it in mind every time. 2 days ago, a new algorithm, the Basel algorithm, was published in JACC, and uses the clinical history, uses the lead 2 and lead AVR. If it the duration from the beginning in lead 2 to the PCAR wave, or the PCAR wave in lead AVR. If it is more than 40 milliseconds, it's positive for a VT. And if you have clinical history and one of these two or both of these ECG markers, it's probably a VT. What I want to say is that we have many algorithms. It's impossible to remember most of them from my point of view. I read this paper 2 days ago. That's why I remember these values. But in this algorithm, the last algorithm from Basel, they pay attention to the clinical history. So it's positive, it's probably a VT. If we have any other comments?
I think sometimes we need electrophysiological study in order to differentiate between SVT and VTs. I have ablated AV-NRT in a patient with inappropriate ICD shocks because his ejection fraction was below 30%, and ICD was implanted as a primary protection. There were many inappropriate shocks in his records, but the only once we obtained an ECG which we could not distinguish between SVT and VTs, and the ICD was only, we had the ventricular lead. Therefore, we have made an EPC electrophysiological study to him, and after we ablated the AV-NRT, there were no inappropriate shocks in him.
I agree with you. There are many times that we cannot distinguish this wide QRS with aberrancy or VT, true VT. That's why these algorithms has not perfect sensitivity and specificity for this discrimination. But we have to keep in mind that most of these patients will go to the EP lab to treat the tachycardia, VT or SVT. So we can make the discrimination with the intracardiac signals. So,
do we have a next speaker, you think? Yaodong Li.
Hello, can you hear me?
Yes, we hear you, but don't see you.
I'm from China. My name is Yaodong Li.
okay.
Can I start now?
Yes, you can start.
Yes. Okay. Yes.
Start. New bumping techniques for VT ablation. Okay. Let's move.
Okay. Good afternoon, good evenings, and today my topic is about new mappings techniques and during VT ablation. And I am Yaodong Li, and from the first affiliate hospital of Xinjiang Medical University in China and in Xinjiang. Today there might be two points and two major points to talking about the VT mapping. The first one is technical difficulties and limitation during VT mapping, and the second one is new mapping techniques during VT ablation. And specifically, the first one is intracardiac echocardiographic and ISE, and the second one is high density mapping. So that's talking about the first part. And we're talking about just give a little review about the VTs, and because the great influence on hemodynamic and the highest degree of malignancy because very threatened to life, and all even we use the anti-arrhythmia drugs really less effective for this kind of patient. And next we're talking about the current status of the VTs. And for the no-structural heart disease patient, the procedure success about 79%, and the overall survival is about 100%. And for the patient who diagnosed as non-ischemic cardiomyopathy, the procedure success is about 16%, and the overall survival is about 74%. So now we're talking about the mapping difficulties. The mapping speed is non-sustained VTs and the VT with unstable hemodynamic. And when we use the visualization tools, but the complex or abnormal ventricular anatomies might be very difficult to mapping and ablation for the VT. And the intelligent mapping systems or correlated softwares, but some kind of disease and some kind of VTs are limitation of substrate-based ablation because of low voltage and slow conduction. And also the electrocardiograms abnormalities, and it's difficult to identification of critical isthmus, and the multi-pharmacology VTs are exchange after attempts ablation are time consuming, especially when using the ablation catheter only. So now we're talking about the first part, the intracardiac echocardiographic ISE. And this is anatomy of the left ventricle and the papillary muscle. Here we can see the anterolateral papillary muscles and the posterior middle papillary muscles. And the most ventricular tachycardia originates in the left ventricular, and coordinate tendon and annulus is in solution, and the papillary muscles connect only forward. Here we can see there are two main kind of anatomy of papillary muscles. One is separated and one is shear-based. And we can see this real-time echocardiogram graphics, and this is the anterior papillary muscles, and it does not touch the ventricular septals, but the posterior papillary muscles tends to close to the septal at annulus concentration. So it's really hard to fix the cancer, even the mapping, the VT. So there are two characteristics of papillary muscle conduction. The first one is all-in forward conduction, and the second one is transverse conductions. About the pacing mapping characteristic, the
next speaker is Enes Elvin Gül from Turkey, is going to present us how to define the critical isthmus during VT ablation. It's a very interesting topic.
To make it, okay, that's fine. So I was asked to deliver a talk on how to define the critical isthmus during VT ablation, and I assume that we already diagnosed the VT based on the first talker, ECG, and now we can move and try to find the isthmus. But it's not that easy, actually. It's because the isthmus are very complex structures and with multiple entrances and exits, as well as there are some like multiple dead ends of activation. So, and we don't know, some isthmus, they might be bystander, some of them can be functional. So it's difficult to find which circuit, which isthmus is responsible for the arrhythmia. And even furthermore, we can, like those isthmus can be responsible for multiple VT circuits as well. And why we are mapping isthmus? Because in some patients the VT is unmappable, or it's hemodynamically it's impossible to map. So then we go and try to find the isthmus during the not during the VT, like in sinus rhythm. This is why we have two types of, like in two settings of cases where we can map the isthmus. One, if the patient's sinus rhythm, VTs are mappable, like I mentioned before, we can go and try to find the voltage map and find those circuits inside the voltage. And we can find, like, map the LAVAs, like local abnormal ventricular activities, and pace mapping. However, VT mapping is more reliable, I would say, but it's the best activation map or entrainment map. We're going to talk further in the next slides. So we know all these circuits. This is modified from William Stevenson's slides and his studies. We know that when we entrain the tachycardia in a faster rate than the cycle length of tachy, we call this entrainment. And we can cause two types of entrainment, either concealed or manifest entrainment. And then we go and look at the numbers. I will talk about numbers later on. However, it's not that simple. So far, we used to know that this is the circuit. It's a two-dimensional imagination of the isthmus and all the circuits. But however, it's not two-dimensional. It's a three-dimensional, because we are missing. We have to just imagine that we have, like, epicardial, endocardial, as well as mid-myocardial, the part of the tissue that we have to take into account, and try to find the circuit, what we are missing in the circuit. And this was proposed by Dr. Roderick Tong, and due to these technical challenges and the anatomical challenges, it's not always successful to map the isthmus, because we have to imagine as a 3D dimensional isthmus or the anatomical tissue. So even though this was a new the editorial in Hayıroğlu, and they even showed that the isthmus must be constrained 3 dimensions, can be like isthmus constrained, or entire circuit is constrained, or can be like you might have unidirectional block in the isthmus, or you might have the conduction velocity in the opposite side of the isthmus. So now we're going to move about. So today our talk, I'm going to focus on this part. So we're going to talk about isthmus, where the exit central part or the proximal part or entrance part of the isthmus. So I'll give you 3 examples on that. So this was a tachycardia, patient ischemic VT. The entrainment was performed. The cycle length was 427 milliseconds, and entrainment was at 380. And you see that there was a concealed fusion, which means that the VT morphology with the pacing is almost identical with the pacing morphology. And then with the PPI, the pacing cycle length is 380 and tachycardia is 427. And if you look at the PPI, which is the return cycle length post pacing after the last pacing beat, it's 420. It's equal to the tachycardia cycle length. So we are like in a circuit. Then we have to look at the next step. What's our stim to QRS and the EGM to QRS duration, which is identical in this case as well. And then the last step to see the ratio of the stim to QRS to tachycardia cycle length, where we stay here, where we stand here. So this 33% in this case, which is the central isthmus line, like mid-isthmus line. So this is the spot that we have to focus and ablate. And as you see here, the radiofrequency ablation here successfully terminated the tachycardia. And the next example as well, here we see again the entrainment of tachycardia, and we see the concealed entrainment with the similar QRS morphology. And however, the return cycle length, which is the PPI, is longer. So if it's longer, so it's adjacent bystander. Then we don't have to look at the stim to QRS to tachycardia cycle length ratio. Another example, the same tachycardia with the different sites of pacing. Again, we're causing concealed pacing here, entrainment. However, this time the PPI is shorter, and it's almost in the. And when we calculate the stim to QRS, it's 35%, which is again in the central isthmus line. Another example again here, we have tachycardia with the concealed entrainment again. Stim to QRS tachycardia cycle length is less than 30%, which is close to the exit side with a perfect QRS match. However, it's not that simple. We know that the same isthmus can be responsible for different types of VTs, which we don't know. This is why sometimes it's so critical and difficult to find the clinical VT if there is no documentation. Then you have to find those all isthmuses and circuits. Nowadays, we do like try to eliminate all those isthmuses, regardless they're responsible for different types of tachycardia. Even though this is more complex, this isthmuses can be responsible more than 2 loops as well. In this case, they represented like this. The one isthmus can be responsible for different tachycardia, and there will be different VT morphology, of course. Here, there is example. So after the entrainment, this is the first step we're trying to do during the VT. But the pace mapping as well can help to differentiate where we are. I mean, try to find the spot. So with the pace mapping, if we are in the exit side of the isthmus, so we're causing actually almost 100% QRS the morphology compared to the clinical VT. However, if we're in the entrance or in somewhere else, it's going to be very, I mean, the poor correlation match with the VT morphology. This is why these isthmuses are so narrow, and the small like placements of your catheter can change the QRS morphology entirely. Here's another example. The pacing side, it matters, which can cause different QRS morphology. Here's a good example from good friends of mine. So it was epicardial mapping in a DCM patient and with a dual decapolar catheter. When they pace from dual decapolar 7-8, they cause like 10% match compared to clinical one. However, when they pace to 9-10, they're so close. If the operators in the EP lab, they know how they're close, like the spacing is too small between 7 and 8 and 9 and 10. But in the 9-10 pacing, it's 100%. It's a really small area of pacing the interest. So then that means we have now exit, entrance, and when we go the mid, it's a mid-isthmus line. And if you look at the VT, we have full diastolic buffer or diastolic, the area we're covering here, which represent the first one is the entrance, the last one the exit, and this is the spot that we need to go and map and even ablate. And nowadays, with the high definition catheter or ultra HD catheters, and with the new technology with the mapping system, we know that this is so-called ILAM, isochronal mapping, late activation mapping. So those areas can be responsible for the isthmuses. So as like in this example, and this is ILAM map is the isochronal crowding of the late potentials where you have to focus. And some studies show that there is a good benefit and the success rate, and the endpoints are very good when you target those ILAM areas. And each mapping systems like we're using in our lab, they have their own ILAM, the algorithm. Another example of the ILAM, you can see here epicardial map, and it's a big area, but when you focus on the isochronal crowding, it's a small area of the isthmus. Another mapping technique that they proposed in 2015 by Jackson is a deep mapping, which is called decremental evoked potential map. Some centers use this PFA, like in Kingston, people using the PFA mapping. So this is the pacing, like program stimulate pacing from the site of interest, and to see what happened to the late potentials. And you get delay, and then at some spot you see that block in the conduction velocity. And then they showed that this kind of, so instead of mapping all late potentials, it's better to focus on the deep mapping and find those the decremental late potentials. And then Andrew Porter Sanchez, they did a huge study on that, and they found that it's the deep mapping is another the mapping technology or tool to map the isthmuses. So now we have talked about the deep map activation, the ILAM map, but especially when you have the patient's sinus unmappable VT, you can go and map the voltage map or late potential map as well. Each center, they call this voltage map and ablation different terminology. To me, they're all quite similar, but the terminology or definition is different. Some center, they call this scar dechanneling. Some of them, they call the lava, like elimination of lava, core isolation or homogenization. But it's like in the scar area, in the voltage area, that you need to target those areas of interest. Of course, I assume the next speaker will be able to talk about these techniques, that the new technologies, not even non-invasive mapping, the tools like ADAS or InHard can help you to define the critical isthmus without even mapping. And there's a strong correlation, especially Spanish group, the Iva Roca and the other people, the Andrew Sanchez, they published the good the studies on that. So the non-invasive mapping or even in intraprocedural ultra HD mapping nowadays can help us to guide and to find the spot. This was another study from our epicardial DCM patient, inferior lateral spot with a late lava potential. We mapped and then they was successfully eliminated all lava potentials. Sometimes it's difficult to map or it's unmappable or the hemodynamic unstable. This was the ARVC patient from our own archive when we mapped and we found that RVOT anteriorly in the epicardium area was the late deceleration zones, and you have the slowing down the conduction velocity propagation over there. And the same spot we can find the lava potentials as well. So again, the DCM patient with the inferior lateral, the late potential mapping showing that the area of interest of the isthmuses when you can map in the sinus to them without inducing any ventricular tachycardia in those patients. Another example as well, the late activation map. Showing that again infralateral spot with the lava signals. So far this is the talk that I want to deliver. It's difficult to finalize this talk in 10 minutes, but I hope I was able to deliver the message. Thank you so much.
Thank you very much. Thanks, Enes. It was a very nice and really concise overview over difficulties and techniques to use in the isthmus. Anybody questions? We know now we have time. May I ask you? I don't do ablations myself. I take care of patients with cardiogenetic diseases, different sorts of cardiomyopathies, which are complicated by VTs in many cases. And as we all know, the structure of and heterogeneity of fibrosis substrate is very different in ischemic cardiomyopathy or dilated or ERVC or similar. How is that translated to difficulties in localization and ablation of the isthmus in VT from your experience? How do you approach the patient when you know in advance if this is ischemic, this is dilated, non-ischemic, this is something else?
Yeah, thank you so much. I think that each center, they have their own protocol. But if you look at the biggest VT centers like in States and Europe, you know, that it's pretty similar in terms of how to start the procedure. Of course, intra-procedure approach might differ. But let's say if it's ischemic, most of the center, they do start with the endocardial mapping first, if it's the first procedure, because they assume that the majority of the substrate will be in the endocardium. Although there's some studies and some centers, they do start with the endo-epi even in ischemic patients. This is the different approach. But the majority of centers, like our center as well, I do start with the endocardial approach if it's ischemic VT. However, if it's non-ischemic VT, to be honest with you, this is a huge definition of like DCM is a huge definition, it's a big definition. We don't know which kind of DCM we're dealing with. So I think ischemic, it's easier to go and focus what we are going to do, but DCM, still a lot of centers, they start with endo-epicardial, but they assume that the majority of the source will be in the epicardium. But I think it still depends which kind of DCM you're dealing with. If it's sarcoidosis that you're dealing with, probably you will find a lot of endocardial and septal, the substrate as well. But if you're going to deal like with the other kinds of DCM, so then you might be like myocarditis, like then you might find more the substrate in the epicardium. I think they're good centers in Italy. Last time I attended one of meetings, they do this biopsy in all DCM patients. It's always better to find which kind of DCM we're dealing with, then it will guide our procedure, because it's not simple, to be honest. I know there are a lot of centers doing like epi-endo that as a first option, but it's not easy because it's prolonged procedure, it's the long GA anesthesia time. This is why we have to know the prognosis and the diagnosis first before we take the patient to the lab.
Thank you.
Congratulations, Enes, for this excellent talk. Do you think that the procedural imaging will guide your strategy, your ablation strategy? I mean,
this is perfect question. Even this can be another talk like imaging in VT. So I think their centers, they encouraging us to use this, like Bordeaux, like the Barcelona, you know, and they show the good result, good like endpoints on that. Even with the imaging, you can reduce number of catheters that you're gonna use. Like you can, you know, just guide on the ADAS or in-heart mapping the tools. But I have seen some centers as well, like Milan, they're not so relying on that. I don't know. I think it depends on the experience of the center. And there's a main limitation of the imaging that it's not simple. You should have your own dedicated EP imager, like the radiologist, to get you the images. I know in Bordeaux, they have their own EP radiologist who is providing those images. But in a normal center, it's not simple to take the patient to the CT and get them. It's not so reliable. You should have really good tools and good radiologists to deal with.
Yeah, I agree with you. VT is a very difficult. Ablation is a very difficult task. The patient must be stable. Unfortunately, the majority of patients are not stable and are mapped during sinus rhythm or during pacing or whatever. I have one question for you. If you had to choose between, among all these, let's say, modalities that we have now during VT ablation, what would you choose? Do mapping during sinus, during nerve extra, during handling the late potentials, traditional late potentials, or lavas? Only one thing.
I think if I have the only one thing to choose and go ahead, I will map all late potentials and eliminate them. I mean, because induction of the VT, it doesn't mean that it's the clinical one, and we're dealing the clinical isthmus or critical isthmus. This might be like bystander isthmus. I think I will go, and there's some stats showing that complete elimination of late potentials had a good endpoint on the long-term success. So I will just go with a good Ultra HD or HD catheters and map and target all late potentials. This is what I will do nowadays.
Any other comments?
I see that Augusto Meretta has joined us as well, and so Mert, please, if you have anything. So, audience, please raise your hand or just speak. Let us know if you have questions. This session was actually very logically planned, and the last talk would be the new methods of mapping that Yaodong Li, and I feel very sorry for him that he was not able to complete that. Yaodong, I see you're with us. Are you still available? Can you talk? Can you leave some comments about the new techniques that can help us? Seems difficult.
Can I ask something to Enes? Enes, thank you for the great presentation. It's very deductive, I think. What is your experience? What are the complications did you experience in the last year in VT ablation in your center? I think.
Yeah, it's. You know, we all have complication. We can't say that there's no complication. There's always complication. There are complications in big centers and big high volume centers as well. I think I think procedure preparation is a key here, because you don't have to rush to take the patient to the lab. You should have really good preparation with your anesthesiology team. I think you should have a plan B in case the patient crash. You should be able to put the patient on ECMO or some hemodynamic and support, and just maintain a procedure, or just get the patient to the CCU or CICU. But I think the complication that the endocardially, it's perforation, and even we like perforation, because then it's not like something we prefer, but if it happens, then we have to go epicardial anyhow. So then we get the epicardial access, we tap the patient, and then we do the map the epicardial space if it's possible. But I think that for the last 1 year, the main complication we had a stroke, which is like this is something that you should train your team how to follow and check the ACT level, or because the main problem was that we changed our ACT machine to the different ICT system. This is there is some difference in the values. This is why I was just guiding like 300, but the actual number was 250, 260. So we got the stroke for the patient. So I think the all kind of complications are open. The main key is that you should be able to diagnose those complications on time. If you're able to diagnose them, I think you're a good operator. This can happen to anyone.
Thank you.
I agree. Pyotr, can you hear us?
Yes,
I think it's about time to close the session, or not?
I believe so. And well, please accept our apologies for the technical issues that you all encountered, and this is beyond our control. But we did have 2.5 talks, I would say, and it was very well prepared. And I sincerely thank speakers and for presenting and for discussing with us.
Thank you all for joining us. Thank you, Gary.